Your Honor, it's a quick condition, and I'll go first. Dr. Steenland, you were in the courtroom and heard Judge Bean's comments just before the brief recess that we had. We can either start with your response to that, if you have one, or I know that you met with all counsel here at a luncheon before we started today. I know that you had prepared in advance a short statement or presentation, and perhaps you'd rather start with that. Your choice.
I would. And I'm free to do so, Judge. I understand that folks would like an answer to this question as soon as possible, and the time has gone by. And I would like to say that we have been as diligent as we can in answering this question correctly, because you can answer it quickly and wrong, or you can answer it after the time's gone by and answer it the best that you can and hopefully be right. And that's been our job from the beginning. That's what we've been doing. There are several reasons that need to be spoken to about the strengths and weaknesses of the C-8 Health Project data that is the basis for much of the work we've been doing. First of all, it was an extraordinary job, Paul Brooks has described it, to collect that much data so quickly and accurately. And it has formed the basis for almost everything we're doing. That said, there's, from an epidemiologic standpoint, a scientific standpoint, try and figure out whether you can determine probable links of disease in relation to higher or lower PFOA levels. There's some weaknesses in that data, and there's the two main ones are, what we'd like to do is know whether people with higher PFOA or C-8 have more disease. And so you need to know who's got disease, but you also have to know when they got it. And you have to know about what their PFOA levels or their C-8 levels in their blood were likely to have been before they got the disease, not afterwards. So we know that from the C-8 Health Project what people's levels of PFOA in the blood were in 2005 and 2006. And we know when people have reported a history of disease at the time of the C-8 Health Project. For example, they may say, I've had heart disease. However, it does not tell us when they had heart disease, nor does it tell us what likely their PFOA level was before they had that heart disease. So if you say someone had heart disease in 1992, we need to know what we think the PFOA level in their serum was before that, not after that. And so that depends on their residential history. Depends where they lived, how far they lived from the plant, whether they were drinking public water or private water. We've spent quite a bit of time reconstructing those residential histories and determining what direction the wind blew from the plant with the particles of C-8 on them, how long it took to get to the ground, and how long it took to get from the ground into the groundwater and into the public water system, so we can estimate what people have been drinking at what point in time. That is a major, major thing to do. To go into all the details of it would take a long time, but it is not an easy thing to do. We have completed that effort. We've published a couple and more things are in the pipeline. I think that will stand as a model of how you figure out what happened in the past from what you know in 2005. We had to figure out what the emissions from the plant was in the air, what went to the river, how much the river communicated with the groundwater supply over time, starting in 1950, when DuPont began manufacturing C-8. And we had to determine how far the particles went before they were deposed on the ground, how long it took to get from the ground to the groundwater. We also had to determine whether or not people were on private or public water, which is not an easy thing to do. The water companies only have some suggestions about that. They can't tell you with accuracy. We had to reconstruct where pipelines were laid. This has been a major thing to do, and it's fundamental to determining whether or not people, what their levels of C-8 or PFOA were in their body before they got sick, which is key. The second thing you need to know is not only what water they drank, but how long it takes to get out of their body, right? Because if you want to know what somebody had in their body in 1990 before they got the heart disease, you need to know over time how much they drank and how fast it got excreted. Well, how do you figure that out? In the literature, there was some data about that, based on about 25 people at 3M's plants in Minnesota. It was not adequate. It tells us that in 3.5 years, about half of the PFOA in your blood disappears. We thought that this was insufficient data to make a real good conclusion, so we planned a study of 200 people, which, and to the credit of the community, all those 200 people have consistently showed up and given us their blood over a 4-year period after those water filters that DuPont installed went in. So after C-8 went out of the water, we could see how fast it went out of the blood. That was also critical. So you need to know what people drink. You need to know how fast it gets out of the body. These things cannot be answered quickly, and they cannot be answered with the C-8 Health Project data. So, that said, the C-8 Health Project data was key to us because it gave us a list of people. It gave us a lot of self-reported data on demographics. It gave us a lot of stuff on cholesterol and blood measured by LabCorp, and it gave us a place to start, really, because in our view, we had to follow people further. We couldn't just rest on the laurels of the C-8 Health Project to answer these questions for the reasons I've explained. We need to find out what people have had in their blood in the past, and we find out when they got this disease, and then we compare disease rates between those with high levels in their blood and those with low levels in their blood over time, not in 2005, but before they got disease. So from a scientific standpoint, that is the only way you can answer this question about probable link. That said, we said once we get the data from Brookmar, it's going to take us 3 years to conduct the studies that we're conducting. I'm going to describe those studies because there's 11 of them, and there's a reason why there's 11 of them. I've described, too, the half-life and the exposure study. We got the data from Brookmar finalized after the reanalysis of the errors in the blood that Paul Brooks described in April of 2008. It is now May of 2011. We have finished our research program and collected our data. We're now putting it all together and analyzing it. And I believe we've done pretty much what we said we were going to do. Furthermore, I think we've done it in a pretty fast time frame for the way these things work in the world. So, that said, let me describe what we thought had to be done to figure this out. I mentioned the half-life study, the study of how fast it gets out of your blood, and I mentioned a reconstruction of exposure over time. So what else did we need to do? Well, first of all, we felt we needed to go back and interview these people again and determine what disease they reported, similar to before, but also when they got that disease, and any new disease they might have gotten since their measurements in 2005 of what their PFOA was in their blood. And so we did that. We interviewed 30,000 community members who were adults, and we interviewed about 5,000 workers at the DuPont plant. We've done it twice. We have also, in addition, matched the records of those 30,000 community residents with both the West Virginia and Ohio Cancer Registry, which the national, I'll get this in a minute, with the National Death Index to find out who died and what they died of, and with the United States Renal Data System to see if they had kidney disease. We take all the sources of information plus the self-report. We add to that the medical record validation that we also are conducting, which has been mentioned is a difficult thing to do, and which we expect to get the last data delivery we're going to get, which is in September, will be the medical record validation. So we've interviewed 35,000 people, and we've matched their records to a variety of disease sources. We've put that together. We've estimated what their past levels of PFOA were in their blood, and we're going to try and figure out, and we're going to report to the court which chronic diseases show, if any, a higher rate of disease in people with more PFOA in their blood over time before they got sick. I challenge, I don't know if I should challenge the other epidemiologists in this world, but I don't think you can do this a whole lot faster and get a decent answer than we've done it. We are scheduled to report on time, I believe, what we know. Now, let me address the cholesterol question, which we've heard some testimony about. We reported We got the data in April 2008, the final data from Brookmore. And in the end of 2008, Tony, was it? On October 8th, which was what, 5 months later, reported to the court that there was an association between cholesterol and PFOA, which we had then published in 2009 or 2010. So we brought this to light, as well as Alan Duckman at WVU. And the problem is that because you see in the blood of people in 2005 that high cholesterol is related, correlated, associated with higher PFOA, you don't know which came first. You don't know that the PFOA preceded the elevation of cholesterol. That's a fundamental thing you need to know, that exposure precedes disease. You can't tell that from that data. Therefore, one of the studies we designed was what we call the callback study. We brought 800 people back in 2 or 3 years later, well, probably 3 or 4 years later, after the blood was measured in 2005. And Dr. Fletcher has headed this effort, and we measured the cholesterol again after those filters had been put in. So when the filters were put in, the PFOA dropped. So the question is, did the cholesterol drop? Because if these things are related in some way, you got to think about it. If PFOA is higher in 2005 and cholesterol is higher in those same people, is that because they run together? For some reason we don't understand biologically about how blood and cholesterol work? Or is it because the PFOA causes cholesterol to go up? Well, you can answer that by bringing these 800 people back in and seeing whether their cholesterol has dropped. We know their PFOA has dropped. We measured it again. Those filters have taken it out of the water system. So now the question is, does the cholesterol drop at the same time? That gives you a whole lot better way to answer the question whether there's a probable link between cholesterol and PFOA.
What else if they're on cholesterol then?
We take that into account. We know whether they're on statins, and we either take them out or we analyze them separately. So that's been our approach to that. So that half-life study, that callback study of 800 people not only considers cholesterol, but every kind of cross-sectional thing was measured in 2005, like immune markers, liver enzymes, kidney function. So all that stuff, if it's been elevated by PFOA, uric acid, when that PFOA goes down, those things will go down. That's the definitive way to find out about that, and that's what we've done. That data has just been delivered to Tony. We'll be analyzing, and we'll be using it and making a decision about whether these biomarkers, what we call biomarkers, cholesterol, uric acid, things you can measure in the blood, are related to PFOA. I won't get into the question of whether hypercholesterolemia is a disease. We'll get into that, but not at this moment. We will say whether we think cholesterol is related to PFOA. And more importantly, we'll say whether heart disease is related to PFOA, because cholesterol, you can have high cholesterol, and it increases your risk of heart disease. But you might not get heart disease. So the question, the bottom line is, from a health standpoint, did you get heart disease from that high cholesterol? Did the PFOA give you heart disease? And we'll answer that question. We'll answer it based on the interviews of 30,000 people in the community and the 5,000 people in the workers. We'll answer it in July of 2012. And if we have an answer before that, we'll answer before that. And for some outcomes which do not depend on the long cohort follow-up studies with the interviews, we will make an answer before, probably. And I'm specifically referring to the reproductive studies. Those studies are independent of several of the things I've mentioned. They don't depend on these re-interviews that we've done for 30,000 community residents and 5,000 workers. We should be able to answer the probable link question on reproduction this year, before Christmas. I think I'm under oath and I won't swear a specific date. But that's our goal, and I believe that's possible. Now, I want to mention a few of the other studies that are being done. I said we designed 11 studies, and I've mentioned a number of them, but not all of them. And the reason is you can't do some studies, one study that's going to answer all these questions about these different diseases. So, for example, we are doing a study of neurodevelopment where we look at cognitive testing, IQ testing in children. David, correct me if I'm wrong, he's leading that 5 to 12 in that age range. And we've got taken these vans out to folks' houses and measured, with great cooperation from the community, 400 kids, if I'm not mistaken. And that will give us a very good answer on whether there's any neurodevelopmental relationship between PFOA and these tests we're conducting. So there's also several other studies that we're doing. We're doing a geographical study of cancer to see whether areas with higher PFOA historically have had higher rates of cancer on a global basis. That is to say, within a census block group or a zip code, have those ones with higher PFOA had higher cancer rates. We've had some difficulty getting data from the West Virginia Cancer Registry because they changed staff. And I mean by difficulty, I mean year, not months, year. That difficulty, I believe, has been overcome. It's not been easy to overcome. I think I could go on and describe these studies, but they are on our website. You can read about them. And every time we find something along the way, we report to the court what's called a status report. We put that status report on the website. It's public the moment we deliver it to the court. We try and provide information to the public as soon as we can, consistently. And you can read about all these studies on our website. You can read all the status reports. So where are we going from here? As I mentioned, we have almost all the data we need now. I think the last will come in September with the medical record validation. We're getting medical record validation on approximately 20,000 people, which means you have to go to the Cleveland Clinic and the Huntington VA Hospital and the Ohio State University hospitals and ask them to provide medical records, and they might be a little busy. And if you have 300 requests, that they might not honor them the next day. So that's been a laborious process. It's key because we need to know as much detail as we can about this disease in terms of the data diagnosis, again, critical, and to validate the self-reports. So, all that said, we hope to take all this data together and integrate it, and then determine whether people with more PFOA in their blood over time have more serious chronic diseases and report on probable links by July 2012 at the latest. And we say report on probable links, we intend to provide data on whether or not there's a probable link for all serious chronic disease outcomes that have been discussed in the literature as possibly linked to PFOA.
Well, let me ask you something about that. Well, why is it all on that date? Why can't it be as you determine?
That's a fair question. I don't have an exact plan on July 11th, 2012. It could be that we can get some done in May and some done in June, some done in July, and we will do that if we can. But as far as the number of such reports, there will be one on each of these chronic diseases that have been associated in the literature potentially with PFOA, and I refer to all the major chronic diseases that involve heart disease, stroke, diabetes, cancer, and cancer is not one disease, it's many. Liver disease and kidney disease. So a lot of major disease classes there. In addition, we'll summarize the evidence for and against, and we'll give a judgment that this is probably linked or not, in our view. And we will also do that for any findings along the way which are unexpected, which are not previously discussed in the literature or suspected, but which pop out and say, yeah, there's something going on here. So I can't tell you exactly how many status probable link reports there will be, but there'll be a bunch. And along the way, as we've been doing for the last 3 years, anytime we find something important that it isn't sufficient to tell us the final answer, but it's an important piece of evidence and it's sitting in our hands, we report it to the court. That's called a status report. We will continue doing that until we deliver a probable link. And we will deliver that probable link as soon as we know, as soon as we confidently can say, this is what's going on. That's all I got to say.
Well, Dr. Steenland, let me ask you